So hello guys, welcome back to another video. We're talking about infections of CNS or neuroinfections. I'm going to go through this pretty quick because it's a very big topic, and I think by now you must have gone through this topic already because your exams are coming close. So let's go about it. So when we talk about neuroinfections, first of all, you have to understand the methods of spread. Let me just try to do this. Yeah, methods of spread. So remember, you have four methods. Okay, you can either have a local extension, which means there is some infection somewhere very close to the brain, and from there it can just extend to the cranium. That's one. Second would be direct implantation. It means the infection is going to get directly implanted to the meninges or into the brain. The third would be hematogenous spread, which means there's going to be some problem with the blood-brain barrier, or maybe the etiology or the causative agent can penetrate through the blood-brain barrier, and it's going to affect the brain and the meninges. Then we have peripheral nerves. So there are some microorganisms which can travel through the peripheral nerves, and then they can reach the central nervous system. Okay, so just a little bit more. In hematogenous spread, you could have three main causes. Either there could be some surface receptors of the blood-brain barrier to which the microorganisms can attach, or there can be a damage to the blood-brain barrier, and therefore the microorganisms can enter through it. Or the third one could be the fact that choroid plexus is usually more vulnerable. So if the microorganisms can get into the choroid plexus, then they can jump into the ventricles. When it comes to direct implantation, it means maybe there's some sort of trauma after an accident. There could be some anatomical defect like spina bifida, or maybe let's say when they're performing lumbar puncture, uh, maybe the needle may not be sterile or this area around the puncture may not be sterile, and microorganisms can get through it. Talking about local extension, like I mentioned, it's just some area of infection. Most commonly, it's the air sinuses, especially the mastoid sinuses and the frontal sinuses. Let's say there's some chronic sinusitis. So there can be a small chance that it can travel through the sinuses and into the cranium. That's one. Then, of course, infected teeth, it's very common, to be honest, and osteomyelitis as well. So what happens is, now we go to the next stage. We are now going to look at the types of infections. Now, in types of infections, you can have two main types. One is meningitis and meningoencephalitis, which is a combination of meningitis and encephalitis together. Or you can have epidural and subdural infections. Please make note that one of these infections can result in another type of infection, it's or vice versa. But basically, just to make it simple, you have epidural and subdural infections, and you have meningitis and meningoencephalitis. Now, to speak about epidural and subdural infections, if you look at the cause of this, just remember local extension, okay? Predominantly the air sinuses. So, for example, consider sinusitis or consider osteomyelitis, okay? They're going to cause an epidural infection, and this epidural infection can cause formation of pus or abscess, and can cause spinal cord compression. This is not very important, but it's just pathophysiology, to be honest. So sinusitis and osteomyelitis will cause epidural infection, which can cause spinal cord compression. Um, Sinusitis can also cause subdural infection. Subdural empyema can result, and this empyema can have a mass effect because it grows and it can have a mass effect within the cranium, and this can cause increased intracranial pressure. Okay, so that's just something to consider. Again, it's not very important. Most important thing is to know that there's epidural and subdural infections, they exist. This is just the pathophysiology of it. Now comes meningitis and meningoencephalitis. Now look, encephalitis is a separate section. Let's just deal with meningitis first. We have three types of meninges: dura mater, pia mater, arachnoid mater. If it's dura mater, it's called pachymeningitis. If arachnoid and pia mater are affected, it's called leptomeningitis. But a lot of times, leptomeningitis can lead to pachymeningitis and vice versa. Now, all of this together, ultimately, meningitis, if it spreads into the brain, then it can cause encephalitis. Okay, so therefore they can progress into meningoencephalitis. Now, meningitis and meningoencephalitis can occur not only in an infectious setting, which I had mentioned for the most part over here, because we say it's neuroinfections as a topic, but it can also be because of some non-infectious settings as well, such as chemical meningitis and carcinomatous meningitis. You don't have to touch too much into this, but I'm sure your notes will have more into it. But I have to move on because it's a very big topic. So you can search more about this. Now, coming to some symptoms, very basic symptoms, right? Always remember there will be fever, there'll be headache, and there'll be neck stiffness, also known as nuchal rigidity. These three are absolutely important to know. Along with this, if there is encephalitis, it can result in neurological deficits. It can result in coma ultimately. Lethargy usually occurs as a result of systemic inflammation, or rather, it's just a systemic, like, how do I say it? Manifestation of meningitis and encephalitis. Okay, so lethargy as well. Please remember this, it's very, very important, especially these three. Along with this, there's also vomiting and nausea, but I'll come to that in a moment. So we are done with the second part, So this was the first part, second part. Now we go to the third part. I'm going to go through this very quickly because there's quite a lot. Um, but here's the thing, okay? It looks complicated, but don't worry. You have causative agents, you can have bacterial, you can have viral, you can have fungal, and you can have something called as others. I just put fungal and others together to make it easy, okay? Now, how do you distinguish between the etiologies? You have to do a CSF examination, cerebrospinal fluid examination. How do you do it? Mostly through lumbar puncture. Now, a very, very important thing, this is usually seen in, this comes in fourth year, but I think, it's good to know. It's just that if somebody has meningitis, or if you suspect meningitis, let's say a patient comes into the ER, nuchal rigidity, all the typical symptoms, headache, fever, etc. You don't do the lumbar puncture directly. Do not do it. Why? Because if there's excessive ICP, excessive intracranial pressure, the moment you do lumbar puncture, the pressure gets released, right? So the pressure gets released at the lumbar area. If it gets released, then the pressure sort of like flows through your spinal cord into the lumbar area, and this pressure flowing through can actually pull the brain, like the cerebellum and the cerebrum, through the spinal canal, and that can cause herniation to the foramen magnum. Okay, so you don't do lumbar puncture immediately. You first try to see if there's excessive intracranial pressure. The way you do that, the best method is CT examination. Okay, so usually these patients are sent to CT scans immediately, and if you look at the CT scan, then you can sort of guess, or you have certain parameters where you can find out, okay, is there excessive ICP? Is the cerebrum sort of distorted from the center? Is there any enlargement of the ventricles? Is there any sort of herniation possibly? So you see all these, and if it looks like as if there's a lot of intracranial pressure, then you don't do the lumbar puncture. You have to first of all do certain maneuvers to lower down the intracranial pressure, and then you have to perform CSF, or you can also do a craniotomy to relieve the pressure if it's too excessive. So this is just something that you have to know. It's very, very important because it's a very practical part of this entire topic. Anyways, so let's come back to this causative agents. You have bacterial, viral, fungal, and others. In bacterial, remember, it is not aseptic. Sepsis means there's presence of bacteria. Therefore, in bacterial, it is always septic. In viral, it is aseptic. Okay, so it's acute. Most common bacterial inflammations are usually acute. Here is pyogenic, so there is pus. It's mostly purulent. The pus formation is very quick. Therefore, even the signs they progress quite quick, and that's why it's called acute in the first place. Now, some organisms, I hope you can really see this, but the organisms, very, very important. You have to distinguish between the age groups. You have newborns, you have children and adolescents, and you have adults and elderly. I'm so sorry for the quality of this picture, but I hope you can see it. So you have newborns, you can have either vaccinated newborns or non-vaccinated newborns. Again, very important to distinguish. Non-vaccinated, remember Haemophilus influenzae, okay? In vaccinated, it's S. agalactiae, monocoque, Listeria monocytogenes. My bad. Hold on. Listeria monocytogenes, and E. coli. Okay. Most commonly, you can mention E. coli. This is often found because, especially like when the fetus is coming out to the birth passage, what can happen is there could be some E. coli infection in the vaginal canal, and this can cause, meningitis. So, um, this is the thing. So it's very, very important that you know this. Then comes children and adolescents. Very simple. Remember Streptococcus pneumoniae. Why is this simple? Because for children, adolescents, and adults, and elderly as well, Streptococcus pneumoniae is very common. Then Neisseria meningitidis. As the name suggests, meningitidis, so it has to be here. Now, you would think, okay, meningitis could it also be in newborns? Just don't include it in that. In adults and elderly, it can be possible. However, Streptococcus pneumoniae and Listeria monocytogenes is more common. So just try to find out a pattern between these. Always remember Streptococcus pneumoniae. Always remember Neisseria meningitidis because the name itself suggests. Always remember E. coli because it's very common. Remember Listeria monocytogenes because it's in newborns and in adults and elderly. Okay, so that's that. Then comes viral. Now, in viral, it can be acute, but mostly it's chronic. So it takes some time for the symptoms to actually develop. It is non-purulent and it's aseptic. Organisms, most commonly poliovirus and Coxsackie virus. Herpes virus is very like the infection with herpes virus is very common. However, for meningitis and meningoencephalitis to occur, not so much. Okay, so HSV, VZV, EBV, CMV, you know it. Herpes virus, very easy to say. Paramyxovirus, measles and mumps, M and M. That's how I remember this. So herpes virus, easy to remember. Paramyxovirus, easy to remember because it's M and M. Enteroviruses, remember this, it's a bit difficult. I personally found it difficult for some reason. I don't know why, don't ask me. But poliovirus and Coxsackie virus, it's very important to know. Then comes fungal. Now this is unique, and that's why I have kept it separate. First of all, it's chronic. Then there are granulomas that are being formed, okay? And there is obviously inflammation. So chronic, it's specific because you can distinguish which organisms are there. For example, in viral, you have to go to the whole PCR testing, etc., to get it done. Bacterial, you have to send it to culture. But for fungal and others, it's usually quite specific. You can make out whether it's neurosyphilis, whether it's cryptococcal meningitis, Lyme borreliosis, and any other infections. Now, organisms, very common. How do you remember it? Syphilis has neurosyphilis in it. Okay, you remember the stages of syphilis. Tertiary syphilis has neurosyphilis. So what causes syphilis? Treponema pallidum. Lyme borreliosis, remember this. Lyme disease is very common even in Czech Republic, okay, because of tick-borne encephalitis, for example. So ticks can spread this. And in borreliosis, in the later stages, in the second and third stages, you can have something called as neuroborreliosis, okay? Now, in the third stage of borreliosis, it's very severe. Second stage of borreliosis, neuroborreliosis is okayish, it's not too severe, but it's essentially called Lyme borreliosis. So, what causes it? Borrelia burgdorferi. Next, cryptococcal meningitis. This is super important. Please remember cryptococcal meningitis. Okay. Yeah, cryptococcal meningitis is the one that causes it. Other fungi other than cryptococcal meningitis could be Histoplasma capsulatum and Coccidioides immitis. Again, do you have to remember this? Please try your best to remember it. Um, Maybe they can ask you for some examples of fungi that can cause it. So therefore, you can talk about cryptococcal, Histoplasma, and Coccidioides. Okay. I don't know how you pronounce that, but I hope I'm pronouncing it right. But yeah, so these are the options: cryptococcal, Histoplasma, Coccidioides for fungi. Arboviruses, Borrelia burgdorferi, Treponema pallidum, neurosyphilis. Okay, it's a spirochete, by the way. This is a spirochete. Remember that. And of course, how can I possibly forget? Mycobacterium tuberculosis. Very important. It spreads through hematogenous route. Okay, so Mycobacterium tuberculosis can cause meningitis. Please remember it. Um, I know that it's very easy for us to always try to remember bacteria and viral, and we don't really care about fungal and others. But please remember, even fungal and other infections such as Treponema pallidum and Borrelia burgdorferi are important. They're very important. So remember, 1, 2, 3, and fungi, which includes cryptococcal, histoplasma, and coccolodes. Okay, please remember them. Now, also interesting thing is that tuberculosis, of course, if tuberculosis spreads, if there is I forgot the name of it, but it's called fulminant, I think, tuberculosis. Basically, it's if there's hematogenous spread from the lungs of the Mycobacterium tuberculosis, then it can go through into the cerebrum, and it's therefore a severe stage of tuberculosis. Neurosyphilis, third stage. Lyme borreliosis, again, later stages. And when it comes to fungal infections, uh, it's mainly found in immunocompromised patients, such as patients having AIDS. Okay, so fungal infections, fungal meningitis, mostly in immunocompromised people. So just something for you to remember. Now, with all of these, okay, with all of these causative agents, always remember you have to do CSF analysis to figure out what's the main cause. Of course, you can also look at other symptoms and signs. There are certain characteristic symptoms and signs for certain causative agents, and you can sort of narrow it down just based on physical examination. But we almost always perform lumbar puncture or CSF analysis. Now, here's the thing. Normally in CSF, okay, let's say in 1 deciliter of CSF, out of 100% presence of WBCs, let's say 1 deciliter of CSF has X amount of WBCs, and this is the normal amount, okay? Out of this X, 70% of it is usually lymphocytes, 30% of it is mononuclear WBCs, and less than 1% is polymorphonuclear, which means neutrophils, So this is T lymphocytes, B lymphocytes, mononuclear, I think includes basophils, eosinophils, etc. But polymorphonuclear is like neutrophils mainly. So this is the normal composition. Out of X amount of WBCs, with X being the normal amount of WBCs in CSF, 70% is lymphocytes, 30% mononuclear, 1% polymorphonuclear. Now, what about the protein and glucose content? It's very important for you to know the normal levels. Protein is 15 to 50, glucose is 50 to 80. The way I remember this is that I put P and G. I put 15 is the lowest, 50 is next lowest, 50 just match it over here, and 80 is the highest. So just remember the numbers 15, 50, and 80. Now, these values can differ from different resources, but just to give you an idea, okay? Now, normal ICP, intracranial pressure, very important. 7 to 15 mmHg is the normal range. Okay. CSF volume, normal CSF volume, 150 ml. Very important for you to know. Now, let's just go over here to have a quick look. You can have a detailed look at this table on your own, but essentially, bacterial meningitis, usually the appearance is clear compared to normal. Sorry, it's usually turbid compared to normal. Opening pressure is obviously elevated, when viral meningitis is normal but can be slightly elevated. Fungal meningitis, same situation, can be normal, it can be elevated. But bacterial meningitis, almost always elevated. Now, we remember we spoke about the pressure to be 7 to 15 mmHg ICP. Well, opening pressure, depending on how exactly you're performing the lumbar puncture, is always higher than 15 mmHg. Okay. Now WBCs, obviously there's going to be a lot greater than 1000 to 2000. Viral, less than 300 usually. It's not as much as bacterial, but you have lymphocytes, because obviously lymphocytes are the ones that mainly act against viral agents, right? So you're going to have lymphocytic predominance. Proteins in bacteria, it's going to be more than 200. In viral, it's going to be less than 200. Remember, each one of these parameters is super important for you to know. Every single parameter needs to be known, okay? But kind of, it's a logical, it makes sense. Now, glucose, viral meningitis, normal, fungal, normal, or it could be low. Bacterial is usually less because the bacteria utilizes the glucose for, proliferation and everything. Therefore, it's lower. Protein, it's higher because of bacterial products, bacterial cell wall, whatever, etc. Yeah, that's pretty much it. So meningitis signs: fever, vomiting, headache, drowsiness, lethargy, seizures if the cerebrum is getting affected, confusion, again, systemic sign of inflammation. Um, and this is photophobia. There can be rashes depending on the agent. For example, I think in Neisseria meningitis, you can have rashes, even in Neisseria gonorrhoeae, causing meningitis. Now you have some signs. Always remember Kernig's and Brudzinski's sign. Okay. Um, so what happens is usually, oh, sorry, my bad. So what happens over here is in Brudzinski's sign, you try to lift the head. There's nuchal rigidity over here. In order to prevent the extension of this or this pull of the spine, the leg, there's a reflex. So you sort of have this flexion, okay, of the hips. Um, yeah, so that's Brudzinski's sign. And with Kernig's sign, you try to lift the leg again. You're going to have this sort of pull back of the neck. Okay. And in meningococcemia, for example, you can have some rashes. So that's that. Like I said, this is a very, very huge topic, where it is what it is. So let's continue. Now let's go for aseptic meningitis. Now what's going to happen is in this question, once you talk about the methods of spread, types of infections, most typical symptoms, causative agents, you then come to the actual meningitis and encephalitis parts. Let's start with meningitis first. Aseptic, literally mention whatever I mentioned over here, appearance, opening pressure, WBC, proteins, and glucose. But for the viral part, okay, so take all these values and put into aseptic meningitis. Along with that, what you have to do is you have to mention certain extra points. For example, viral meningitis is usually more common than bacterial meningitis, especially in adolescents and in adults. Usually it's less fulminant than bacterial. Bacterial is very serious. Aseptic meningitis can be mostly self-limiting, and you usually perform nucleic acid sequencing, such as PCR, for example, of the CSF to reveal the causative agent. Okay, that's pretty much it. Aseptic meningitis, clear. Um, then comes acute pathogenic meningitis, bacterial. Now, why or how is the bacteria entering the blood-brain barrier? For example, to the surface receptors, to bacterial lysins. Okay. Now, what's the macroscopy of acute pathogenic meningitis? Again, for this also mention whatever is there in the table. All right. So in the table, you have bacterial meningitis. So mention, sorry, I think it's a bit confusing for you guys now. Moment. Yeah. So mention whatever is there over here. Okay. Um, yeah. Now let's come to macroscopy. So does it look complicated? Yes, but actually it's pretty simple. I'll explain how. So first of all, remember it's bacteria, it's pyogenic, so there'll be pus, right? What's going to happen is you're going to have exudate pus, okay, on meninges on the surface of the brain. Example can be seen over here. There's some yellowish, you see this yellowish area. So that is basically pus, okay? So you're going to have that, obviously, first thing. The second thing is, remember meningeal vessels, okay? And remember purulent CSF. I just want you to remember this. Exudate, meningeal vessels, purulent CSF. I just want you to remember these three things for macroscopy for acute pyogenic meningitis, okay? Exudate, I already mentioned to you. Exudate on meninges, done. Now comes meningeal vessels. What happens is, you have meningeal vessels, okay, vessels in the meninges. They are going to become enlarged, which means they're going to become prominent. Okay, they're going to become engorged with blood. Okay, then there will obviously be cerebral edema because if there's stasis of blood in the meningeal vessels, obviously they leak out, right? There's also destruction to the meningeal vessels, so the fluid will leak out. There'll be cerebral edema. Okay, that's the story with meningeal vessels. Then comes purulent CSF. What is the deal with this? Not only will you have pus, but pus also contains neutrophils, right? So CSF in general becomes turbid. It becomes filled with neutrophils, and there's a lot of neutrophils in the subarachnoid space. Okay. Now, because subarachnoid space is it is the closest in contact with pia matter. Sorry. Okay, now let's come for the signs and symptoms. I already mentioned this, just mentioned the same thing. Classic triad, headache, fever, neck stiffness, or nuchal rigidity. Meningeal signs, especially nuchal rigidity, which is they would want to like tilt their head back, nuchal rigidity. Kernig's sign, Brudzinski sign. Again, I already covered this. Okay, so classic triad is one. Meningeal signs is another. The last one is photophobia, fear of light. Phonophobia, can't listen to loud sounds. And then you have some neurological deficits, if confusion, loss of consciousness, inability to concentrate properly, all those things. Treatment, bacterial, so give antibiotics. That's one of the main things. Then complications. I mentioned to you, herniation. If there's acute pyogenic meningitis and if it's too severe, systemic inflammatory response, right? Fibrosis can occur because the meninges can try to heal and even the cerebrum can try to heal. And if fibrosis occurs, there can be a chance of the CSF block. And when the passage of the CSF to the third ventricle to the fourth ventricle gets blocked, then there'll be buildup of CSF. It can cause hydrocephalus. Then cranial nerve palsies because of increased ICP. Seizures, again, due to increased ICP, which will compress the cerebrum. Can also be that there can be infection of the of the cerebrum, and that can cause seizures. Phlebitis, inflammation of the vasculature, especially the veins. Again, meningeal vessels, engorged, prominent, cerebral edema, engorged, there's stasis of blood, can lead to thrombus formation, can lead to inflammation of the vessels, and this thrombus can break and can cause emboli formation. Okay. Then cerebritis, which is just inflammation of the cerebrum. Inflammation of cerebrum causes abscess formation. This part I'll explain in encephalitis. Okay. So that's basically acute pyogenic meningitis. Again, for this, you can mention the causative agents. I already mentioned over here, depends on the age group, newborn, child, adolescents, adult, and elderly. You can't see it. This is what it is, adult, elderly, Streptococcus pneumoniae, Listeria monocytogenes. Yeah. All right, that's pretty much it. And uh, then you have a picture over here. You can see this. So here you open the cranium. Okay, you open the skull. You can see that the meninges, like the vessels, there's a lot of blood spots over here. Okay, that's because there's bleeding. There's pus over here. Okay, and it looks cloudy as well, right? Usually the brain shouldn't look this cloudy when you do craniotomy, but yeah. Now, please excuse all these parts. This is just my check. I'm reusing papers for making notes. So yeah, that's that. Now, we did virus, we did bacteria, we have fungal and others to go through. So let's look at it. In others, we mentioned Mycobacterium tuberculosis, so tuberculosis meningitis. Now, to what extent do you have to go into this? It really depends if the professor asks you in depth, although I hope they don't because it's a very big question. But TB meningitis, it's pretty sim. It's more or less the same. Here you have diffuse meningitis. Okay, most usually it's usually accompanied by encephalitis. There's high protein levels in CSF, and usually you're going to have granulomas. These granulomas will coalesce or what do you say? They'll combine together. Okay, and they'll form well circumscribed tumor-like mass, and there'll also be central caseous necrosis around these granulomas, and they can undergo calcification, and radiographically you can see them as clear calcification spots. Also, if you do a culture, you can see that it's acid fast. Neurosyphilis, you can go through these notes. Again, I'm just going to like touch up on them to a very basic extent. You can have meningovascular neurosyphilis, you can have paretic neurosyphilis, and you can have something called as tabs dorsalis. In tabs dorsalis, you're going to have dorsal root damage or sensory root damage. Therefore, you lose sense of position. There can be ataxia. There can be loss of deep tendon reflexes. There can be Urgell-Robertson pupils where they can accommodate to where the pupils can constrict and dilate for accommodation, but when you shine light, they do not accommodate. Then loss of pain sensation because it's sensory damage. That's stabs dorsalis. Okay, dorsal part is usually of the spinal cord is usually sensory. Okay. Then paretic neurocephalus. Paretic parenchyma, just remember it like that. So there is diffuse infiltration uh, of the parenchyma of the cerebrum. Therefore, you're going to have loss of neurons. Therefore, you're going to have, loss of mental abilities, loss of physical abilities. There can be dementia. Okay, so paretic neurocephalus just means involvement of the cerebrum as well. Meningivascular is nothing but the fact that there's going to be obliterative endarteritis, inflammation of the arteries, especially the intimal layer of it. This inflammation of the intimal layer will cause lumen narrowing, obviously, and this can cause ischemic stroke. Okay, that's just neurosyphilis. This is usually seen in HIV patients. It's more common. Okay. Now, neuroborreliosis, that was what we mentioned about Lyme borreliosis. Um, it literally just mentioned that there can be meningitis, there can be encephalopathies, you know, um, dementias, mental loss of mental abilities, loss of physical abilities, maybe problems with movement, polyneuropathies. Again, it's just like words that you kind of have to throw in there. Facial nerve palsy is pretty common. Okay, so in neuroborreliosis, so it's just I would say just mention neuroborreliosis. Don't go to too much extent. If they ask you what's the problem, just mention the typical signs of meningitis, typical problems associated with encephalitis. Just end it over there. Now, when we talk about fungal, it's pretty much more or less the same thing. I would say meningeal symptoms, encephalitis symptoms, um, and yeah, I would just explain it briefly. Although I would say that I do have, just give me a second. I would say there is some information regarding fungal encephalitis, so you can sort of put it into meningitis as well. Okay. Now let's go for encephalitis. Encephalitis, same problem. Viral causes, arboviruses, the ones that cause neuroborreliosis, for example, herpes viruses, same thing. Bacterial, mostly secondary to meningitis. So usually when there's a bacterial infection, first meningitis occurs, then encephalitis occurs. So throw in the same etiology. Now, what you have over here, interesting, is protozoal. This is something that we didn't mention in meningeal causative agents. Very important to know. Toxoplasma gondii, neurocysticercosis, amoebiasis, or under this Naegleria, which is caused by Naegleria fowleri. Now, with the viral, you also mentioned HIV, and you can mention the measles and mumps again, which I already mentioned earlier. So let's go through it. Now, when you talk about the encephalitis part of this, mention all the signs and symptoms of meningitis. Then you come to encephalitis. Encephalitis bacterial is usually localized. What happens is there's usually liquefactive necrosis in the site of infection. So a cyst is created, space is created, a cavity, and in that there'll obviously be pus because it's bacterial infection. So you have a cyst with pus, you have liquefactive necrosis. You have suppuration, you have purulent inflammation, which are one of the main parts of bacterial meningitis. Then surrounding it, you'll have edema, you'll have granulation tissue, you'll have new vascularization, and you'll have reactive gliosis. Okay, 4 points to consider. Other than this, typical increased ICP. If there's an abscess rupture, it's just a complication. Okay, that's it, done. Now, viral meningitis. Viral meningitis, very common. Okay, meningitis, like if you have viral meningoencephalitis, viral meningitis is almost always present. Some characteristic features, cell infiltration. What do you think? Obviously, mononuclear. Okay, microglial nodules, perivascular lymphocytes. Just throw in these points. Um, What's interesting is if there's gray matter inflammation, it's called polioencephalitis. If it is white matter that's getting inflamed, it's called leukoencephalitis. If both, then it's just a combination of polio and leuko. That's all. Now, causative agents, arboviruses, what do they cause? TBE, for example, dengue, malaria, yellow fever, the ones that are carried by mosquitoes. So the way you remember this is tick-borne encephalitis, very common in Czech Republic. You go to the Voka Shaka, you go to, especially during the summer vacation, um, there's a high probability of one get acquiring this. Um, then HSV, HIV, HSV2, CMV, VZV, varicella zoster virus. Each of these have specific, when specific pathophysiologies. So you would have to go through this in greater detail. I'm not going to touch upon this too much. It's just that HSV1 can cause temporal lobe necrotizing encephalitis. HSV2 can cause severe disseminated encephalitis, whereas in adults it's mostly meningitis. That's it. In varicella zoster virus, it's usually after reactivation, it can cause shingles. Shingles because here what's going to happen is there's going to be encephalitis in immunocompromised. And that's why it's included in this topic. Cytomegalovirus, again, usually in immunocompromised and in fetuses. In utero, it can cause sensorineural deafness. These 4 points are very important to remember. This periventricular calcification, ventriculomegaly, and microcephaly. I remembered this perfectly for my exam. You have to know these 4 parts, okay? In adults, it can just cause subacute encephalitis, and you can usually see owl eye inclusions, okay? Now, other than this, we also have rabies. I'll mention that over here. So rabies is usually by a bite of a dog or bat. Again, you can go through the notes just to get a brief understanding of this. It's pretty self-explanatory over here. You have to remember every single part of it just to be on the safer side, especially for rabies. For HIV, just know that it's mainly caused because of the medications that one receives when they're having HIV. However, you can also have HIV infecting the neurons or the glial cells, as mentioned over here. And this can cause an activation of an innate immune response. And this immune response will actually damage the cerebrum and can cause encephalitis. Okay. Now, SSPE, again, all of these are important for you to remember. They can ask you. But to what extent they can ask you is very variable. It really depends on the professor. SSP, subacute sclerosing parencephalitis. Just remember it's a progressive encephalitis leading to death, okay? And it's caused by measles virus. The actual infection occurs during infancy and childhood. However, the neurological signs appears later, and it is characterized by a diffuse encephalitis, otherwise called panencephalitis. There's going to be, gray matter and white matter affected. And once the neurological signs presents in adulthood or adolescent period, death usually occurs within 2 years. Now comes the protozoal part. Okay, so again, Toxoplasma gondii. Um, this is usually found in newborns, and it can be acquired transplacentally from mothers with active infection. Very important for you to remember these 3 parts: choriorhinitis, hydrocephalus, and intracranial calcifications. Just remember calcifications because these form granulomas and very distinctive features. And obviously, they're not going to get resolved. They'll form calcifications. Hydrocephalus almost always found in many of the meningitis and encephalitis cases. Chorioretinitis, something that you have to remember. Cysticercosis, you're going to find cysts within the brain, very, very characteristic. You have to remember this. Amoebiasis, naegleria caused by Naegleria fowleri. Freshwater, if you're swimming in stagnant freshwater, there's a chance you can acquire it. I think even this is quite common in Czech Republic, but I would suggest you to cross-check this. Then comes myelitis, which is nothing but inflammation of the spinal cord because myelin over here is going to get damaged very frequently. And this can cause paralysis and sensory loss. If there's gray matter getting affected, there's poliomyelitis. If let's say, wait, I have it here. Yeah, gray matter usually gets affected, poliomyelitis. Um, And over here, I mentioned how exactly it would work pathophysiologically and what the signs are. You have paralytic poliomyelitis. You can have bulbar poliomyelitis. This bulbar poliomyelitis is going to affect the brainstem because it's bulbar. if it's going to affect the brainstem, you know that there's respiratory centers and there is cardio centers. So there can be respiratory compromise and death, and can also possibly affect the cardiovascular rhythm. And yeah, then you have bacterial myelitis, which is bacterial inflammation, mainly caused by some specific bacteria such as Mycoplasma pneumoniae, uh, tuberculosis, syphilis, and brucellosis. Fungal myelitis, cryptococcal infections, and Coccidioides immitis, already mentioned previously. Parasitic Toxocaria canis, Tenia solium. I remember Tenia and Trichinella and Toxicaria. But echinococcal is like, I think you, as you keep revising, it sort of just grows into you. You remember echinococcal. So, um, I know I didn't finish a lot of these things, but hopefully they are self-explanatory and you can read through them. But again, if I would have to go through in detail, it's going to be a very, very big video. So I hope you guys enjoyed. If there are any questions, please feel free to hit me. And all the best for your exams. Take care.